Questions that are, what are the diagnostic criteria for atypical HUS? It's we don't get diagnostic testing for mutations. First of all, it takes weeks. And second of all, most hospitals won't let you send it until the patient's an outpatient because it's expensive. So the diagnosis is a clinical diagnosis. It's based on patients who come in with microangiopathy, thrombocytopenia, and anemia, and a microangiopathic smear. If you're considering a diagnosis of TTP, you can send an ADAM-TS13 and see if it comes back low or high. If it comes back high, usually patients are initially treated with plasmapheresis until they get a better feel for what it is, although I would argue that it's becoming more common than if someone comes in with a creatinine of 12 and a platelet count that's only down to 110, probably you would move to eculizumab sooner rather than later. But there is no absolute test that tells you someone has HUS. It's someone who looks like they have either TTP or atypical HUS and they don't have an ADAM-TS13 deficiency. Should I stop Xarelto before colonoscopy in a patient with a history of PE? Yes. Temporarily. The one thing is it depends on how recently they had a PE. I would say unless the colonoscopy is urgent and the patient's been anticoagulated for less than 3 months, I would put off switching him, just taking him off Xarelto for that period of time. But you don't really have to be off very long. You can be off for 24 hours, but if they want to do a biopsy, they can't if the patient's been anticoagulated. So usually we'd stop for 24 hours and start again as soon as the procedure's over. What about DOACs in cancer patients? Didn't somebody come up and ask Jean about that afterwards? So DOACs in cancer patients, there are several ongoing studies that suggest that it is probably okay to put patients on DOACs, but those studies are still not completed. But in general, there is an increasing adoption by doctors empirically to put patients on DOACs after a certain period of time if they've had thrombosis and are having continued therapy. And we await the results of those trials. I should have you up here answering questions for me. Has any study tried to replicate the apparent seasonal variation in VTE in other parts of the world? Not that I know of. Okay, and please review the... Fine. I think this one is one we should answer individually, not for the whole group. Something about the association between a very high platelet count and the risk of bleeding in a patient with essential thrombocythemia and acquired von Willebrand's disease. I'm not sure what the question really, that's why they have an increased risk of bleeding, because they have acquired von Willebrand's disease and they're on aspirin. That's a bad combination. Okay, any other questions? Yep.
Do we still do bridging therapy?
Bridging therapy back to Coumadin for patients with thrombosis? Yes.
Right, because I was seeing a recent article that's saying that maybe it might not be necessary anymore.
Not in my experience. Well, it depends on what you're bridging to. If someone's going to take a DOAC, you don't need to bridge that. You just restart the DOAC because it's not the same as Coumadin. The reason we bridge patients with thrombotic risk is because Coumadin drops protein S and protein C about the same rate it drops protein factor 7, and the other clotting factors lag, and so you can have a transient period of hypercoagulability when you're Coumadinizing somebody. So in someone who has has VTE, you need to bridge them to Coumadin. The only group of patients that tend to get started on Coumadin without bridging are patients with no history of thrombosis who are being anticoagulated because they have AFib. And the cardiologists routinely Coumadinize patients without bridging in that situation.
Sorry, I was asking more like surgery, like pre-op, like stopping, like Coumadin, and then
If someone's at high risk for VTE, they should be bridged. Yeah, because you have to stop the Coumadin many, many days before you're going to do major surgery. Okay. Yes?
I'm sorry, if they have said this, I just want to ask one more. How do you get, you obviously give the vitamin K when you're dealing with Coumadin, and then you get hits. You give vitamin K. And you talk about Coumadin skin necrosis during, how does that happen if you can talk about that again?
About why you could be at risk for Coumadin skin necrosis? For exactly the same reason that people with protein S and protein C deficiency get Coumadin skin necrosis. Because the protein S and protein C, usually it's people who come in very anticoagulated, who have an INR that's very high. They can have, for reasons I don't know the answer to, I don't know if other people do, they can have vanishingly low protein S and protein C levels. And that's what predisposes to Coumadin skin necrosis.
And then how does that do that? What's the mechanism? You get, it's
You get microembolization, you get clotting, yeah,
clot there,
microvascular clot.
like under just subcu, in the subcu area, epithelial.
I mean, it's, you know,
Have you ever seen it, by the way?
yeah, I have. Only once or twice. I mean, usually it's classically associated with babies, you know, who actually have congenital protein S and protein C deficiency. But you can mimic that in that setting. Yeah. We are, I thought we answered that. There is, so the answer is we don't know. There are some studies that are ongoing. There's been a lot of, in the community use of DOACs for HIT, and it seems to work. And we are awaiting more data. It's probably okay. Yep. So that's an underestimate of the number of features of HLH. They tend to have fever, they can have low counts, they tend to have very high ferritins. I mean, if you did a survey of ferritins in the hospital, everybody who's sicker than a bee sting probably has an elevated ferritin, and in fact, the criteria are very relaxed. How do you tell? Well, for one thing, cytopenias actually are more striking in HLH than other things. And so that's one of the things that should make you worry. Yeah? Oh, yeah. No. I mean, I'm telling you that the stories that I told here are people who've been sick for months. So I think when patients come into the ICU and look very, very ill and you have no idea why, you know, most patients who come in septic shock, you identify a source of infection. So patients who look like they're in septic shock and you don't culture anything and you can't figure out what's going on with them, and if they have prominent cytopenias, those are patients I would worry about missing it and would have a hematologist evaluate them, especially if they have a ferritin of 50,000. So I think it's not so urgent that you treat the minute they walk in the hospital that you don't make a diagnosis. I mean, I think the problem with HLHs is that most of the findings that are diagnostic are nonspecific, with the possible exception of soluble CD25, which most people can't get in less than a week. So you need to convince yourself pretty clearly that that's what it is. In general, people are more convinced when the ferritin's really, really high, although we did a study that shows that the ferritin being really, really high can be from a lot of other things. In children, a ferritin over 10,000 is 95% sensitive and specific for HLH, but in adults, it is not. So I think that it's really a matter of being aware of the diagnosis, having people think of it, and a hematologist decide whether they think they need to get a bone marrow and do other testing to make sure that that's not what it is.
So just on your question that you had as an example for the HLH,
Mm-hmm.
what is it, just to be complete, what, you threw in there a CAT scan with diffuse infiltrates. When somebody has that, has something like that, you start thinking, you might start steering away from HLH. Well, what was the purpose of the infiltrates there? Just, I mean, is there,
It's the way the patient presented.
and what are those infiltrates like in that real patient then?
Who knows?
Part of HLH, anything with the infiltrates and,
I mean, I think patients are never completely straightforward. He may have had ARDS. He may have had viral. May have started related to a viral infection. We don't know always. We can't always tell what the trigger for HLH is.
my question is, would those infiltrates,
They're not classic. No, they're not one of the diagnostic criteria.
and then how common is fever in HLH?
100%. If a patient comes in and has been sick for any length of time and you're thinking they have HLH and they don't have fever, they don't. And the other thing that's striking is that although it's not one of the clinical criteria for diagnosing HLH, I've never seen a patient with HLH who didn't have abnormal liver function tests. Yeah. The question is, would I consider HLH part of the differential diagnosis of an FUO in adults? Absolutely. Yeah. Okay. We done? Oh, but don't they have a break?
No.
No? Oh.